Yeah, oh yes, very much so. I don't know the extent of that, but in the same way as a plan might decide to have very few specialists, in a category, say like HIV, where the treatment is very expensive, to discourage types of patients from being in them. The practice could work on a redlining basis, and that certainly is not good for society when that happens. It's not good for markets because the winners in those markets aren't the people delivering the best services.
No, I appreciate that. Unfortunately, I have heard from physicians, particularly physicians who serve underserved communities of color, who speak in language with dealing with populations who don't in language. Also, particularly certain populations. I've heard from physicians who practice in those populations that they've been having challenges with contracts. And one can argue, is it them or is it the patients they take care of? And hopefully we can do more to be sure that those communities who actually have greater needs can get access to the care they need, including primary care in those communities. Thank you.
Yes. Yeah, if I can say one more thing on that, is that there was a slowly developing trend towards narrow networks over the years, and all of a sudden it was thrust upon the scene when that approach was so attractive on the exchanges. And it didn't surprise people, but it just started in 2014. And I've seen a lot of, patterns and networks that don't look right. And it's really hard to say, given that it's so new, how much of it is, I think there's, especially like ophthalmology, very specialized. If you have a retina problem, you only go to a retina specialist. Mm-hmm. How much of that is known? And this was actually a reason I got into, it's really important to have a good appeals mechanism, saying, I have a retina problem. My ophthalmologist says, don't go to anyone who's not a retina specialist. And I think these other issues are just starting to come out now. And, that's an important role for policy to see the degree to which this is happening and come up with solutions.
Well, pediatric subspecialists in particular is a challenge because 20% children, smaller percentage with chronic diseases, and not a lot of the specialists, not often in the same geographic area as a plan may traditionally be in, yet they won't have a contract with a pediatric subspecialist who actually specializes. And then you start talking about subdivisions of, and a college just doesn't take care of every single type of cancer, so forth. Thank you.
Okay, I believe Senator Monning, question, comment?
Thank you, Mr. Chair. I want to thank you and the staff for organizing this. Doctor, thank you for your presentation. I also want to follow up on the network adequacy issue. Different areas provide different opportunities, rural versus urban, et cetera. But how do you define network adequacy? Is one of the indices a patient who has coverage under a network and they've got a list of providers and they start trying to get an appointment? What determines if their ability to get an appointment is adequate or not adequate?
Yes, I think this is a challenge to not only make these, even if you get the information, doing surveys, then you have to still analyze it and make judgments as to what is adequate. I can't tell you what is adequate.
And maybe we'll hear from later panels, but are there defined criteria currently for what we as a state consider to be adequacy?
Yeah, I would say, at least looking nationally, much of the existing state-level network adequacy legislation came 20 years ago when HMOs were becoming, more of a factor. And they probably haven't been revised much until now. Now, all of a sudden, with a very different focus, network adequacy is an issue again.
Right, I mean, we've expanded eligibility, but eligibility without access, it's shallow eligibility combined with high deductibles where people by law have to have a plan. They can't afford one with more comprehensive coverage, so they're paying out of pocket anytime they go for medical services, and they have basically catastrophic high deductible coverage. One other thing on that network addicts, you mentioned speedy appeals being one mechanism. Could you expand on what you mean by speedy appeals?
Yes, well, speedy appeals means that, and I've thought of it more in the subspecialist area, that, that my condition, I've been told should be treated by a subspecialist. You don't have any within, that I can access in my area. Give me permission to access an out-of-network specialist so I can get these services.
And the speed would be the turnaround. You call your plan, explain I need this specialty. It's not in my network.
That's right.
Give me a referral that you will cover under our plan. Is that
Precisely.
the nature of the appeal?
Yes.
Great. Thank you. I think I'll hold further questions for later panels. Thank you, Mr. Chair. Thank you.
A couple comments, maybe some questions. In one of your opening remarks, you had mentioned consolidation it's going to happen and it's increasing. And that's obviously the reason why we're having this hearing. And yes, the markets are reacting to the Affordable Care Act, but my biggest concern is that a good thing? Is that good for the consumers? Because you have a consolidation, yes, providers, they want to, new docs want to work 9 to 5. They don't want to open a practice. Medical groups are consolidating, hospital systems are consolidating, health plans are consolidating. But is it good, or is it lead to monopolization and then therefore price increases? That's my biggest concern. Do you see a trend of that occurring, and is that a potential problem with consolidation?
Yes, well, and many times when people discuss these issues, the discussion goes where, yes, I know that providers have to do more now than they used to, but merger is not the only way to achieve that. There are all types of contracting arrangements, call them virtual consolidation, where different providers work with each other. There are lots of instances where, a large multi-specialty group will partner with a hospital to, say, under an accountable care organization to take care of a group of patients. They're not merging. They're remaining independent. So what I'm saying is that I think these forces, these requirements, these realities that are pushing in the direction of consolidation, to the degree that they could be managed without mergers, I think we'd be better off, because mergers inevitably do lead to higher prices. Particularly in the hospital area where the literature is the most voluminous and clear, the price increases are quite substantial. And the studies I've seen just have not found quality benefits. So if you're asking, given that some consolidation is inevitable for these changes in medical delivery, is the end result a good thing? I guess it really is going to depend on how worthwhile how much is payment reform achieving? How much of an increase in quality is electronic medical records achieving? So in a sense, the things that are leading to consolidation, and actually I think many of them predated the Affordable Care Act. They were just the direction medical care delivery was going. I think I lost my train of thought, but I'll get it back in a second. So in a sense, I guess it's the whether these directions we've set the system in, hopefully they'll turn out to be worthwhile because they are resulting in greater consolidation, which is a negative.
Right. So you'd also made a comment about broadening the antitrust policy. I mean, obviously, we have the various antitrust, the Sherman Act, you've got the attorney generals of each particular state that do it, but it seems by broadening that ability, then you also have to have an attorney general that's willing to go after and the individuals that are collusing, et cetera, but it seemed like it's a very costly. How is that going to, how do you see that as a benefit, though?
Yes. Actually, it's not so much broadening the authority, but broadening the enforcement. In other words, our existing antitrust laws can be used, to address situations of, say, a hospital acquiring a large physician practice. And in a recent case in Boise that actually involved a hospital system acquiring a fairly large family practice. The Idaho Attorney General sued on the basis of the vertical issue, that it was not good for consumers that a hospital acquire this group. The Federal Trade Commission just challenged it on the basis of that combining this group with other medical practices the hospital already owns would monopolize the physician services markets. So, and I think the reason that they did that is that this issue of acquiring physician practices in large scale is recent, and there's really not much of a research literature to tell us, is this going to lead to higher prices? So that literature is coming out now. People are doing studies, they are getting those results. So I would think that it's the natural course of events, just mainly a matter of timing, as to when the antitrust enforcers believe they're ready to win cases based on that literature.
Then you also had mentioned a comment about hospital ownership of medical practices, but how is that germane to California unless you use, the different model? Because in California you have the corporate ban of medicine, so hospitals can't legally purchase practices or hire physicians.
Yes, I think this issue is less an issue for California than most other states, because the corporate practice of medicine prohibitions has made it more difficult, more expensive for hospitals to purchase physician practices. They can do it, but they have to spend a lot of money setting up foundations and have a number of restrictions on how those foundations operate. So it's not as easy as in other states. And actually California has the benefits of some, very viable medical groups, independent medical groups, and independent practice associations, which you don't see in most other parts of the country. So in a sense, as far as a California issue, it's probably lower on your list.
Okay. All right. I don't have any other questions or comments. I want to thank you for your time. We will now move on to item number 3, section number 3, lessons and recommendations from Massachusetts. We have David Seltz, Executive Director of the Massachusetts Health Policy Commission. Good afternoon.
Thank you very much for having me here today, Mr. Chairman, and through you to the esteemed members of this committee. It is really an honor and a privilege to be here in Sacramento, California today from Boston, Massachusetts, to engage in this conversation on what is an incredibly important topic. And first want to really commend you, Mr. Chairman, and this committee's leadership in really thinking about healthcare affordability as a key component to healthcare access. We talked a little bit earlier about what does access really mean. And we think in Massachusetts, it's not just about having an insurance card. It's about having the ability to get the care you need at the right time and at the right place and at the right price. And that's something that we have been really working on. Massachusetts, as many of these committee members know, has a long, proud history of being a laboratory when it comes to healthcare policy issues. And this dates back to the 1980s when we enacted a number of insurance reforms through to 2006. When Massachusetts became the first state to pass a healthcare reform access law, which ended up becoming the model for the Affordable Care Act. And since that time, when we passed that law in 2006, our state has been very focused on healthcare cost containment and how we can have a sustainable healthcare cost containment growth over time in order to ensure that we meet that promise of being able to hold access for all of our citizens. We came here today, and I'm joined by my colleague Colleen Elstermeyer, who's the Chief of Staff. We flew across the country because we think that a healthcare cost containment issue is one of the greatest challenges facing this country. And we think that states have a central role to play in developing the solutions. And so we are here in a spirit of partnership to share with you about some of the lessons that we have learned and want to support this committee and this state in thinking about potential paths forward. Our work has culminated in a major reform that we passed in 2012, a healthcare cost containment bill that is singularly focused on reducing healthcare cost growth to something that is more sustainable over time. And we have targeted that at annual growth of 3.6% year over year. That is an aggressive target for our state, which in many years had 7, 8, and even double-digit growth in medical expenditures year over year. And it's a significant portion of our state's economy is tied up into healthcare expenditures. But we believe that having that sustainable growth is incredibly important, not only for state government and for its budgets, but for families and their budgets and for businesses in being able to offer great health insurance. We have are early in our experiments in thinking about states as a laboratory. We are only 3 years into this endeavor. I am here today to share some of our initial results, and the punchline is I believe that they are promising. So a little bit around our strategy in Massachusetts to address healthcare cost containment, and I will then focus really on what this committee's hearing today is around consolidation and provider markets. The vision that you see here is really the 4 pillars by which we think about addressing healthcare cost containment. It is a broad strategy. It includes both changing the way that we are delivering care and thinking about transforming care that is more patient-centered, focused on primary care, the team-based approach that allows physicians and other clinicians to work at the top of their license, that is supported by different ways of paying for that care and alternative payment methodologies or global capitation budgets, which provide incentives and rewards for providers that deliver efficient care. To 3, developing a value-based market, which here, what that really means is many of the strategies that Dr. Ginsburg was talking about before, and having a healthcare marketplace that rewards those providers that provide the best care at the right price, and that volume is directed to those types of providers, and that we have a competitive marketplace. And finally, we realize that we have to include purchasers, and by this we mean consumers and employers, in these conversations and giving them the right information and tools to be able to engage and make the right decisions for them, their families, and their employees. I want to spend a minute to talk about our state structure, because I am here from the Health Policy Commission. The Health Policy Commission is a new state agency. It was created in this law in 2012. I am proud to be the first executive director of this agency. And the first employee of this agency. Important to note that the law actually created 2 state agencies. One, the Health Policy Commission, which was brand new, and second, a Center for Health Information and Analysis, which was actually just a reconstitution of an existing state agency. The Center for Health Information and Analysis is really a data hub. It is an independent agency that's primary focus is providing data and information both for consumers and for policymakers to be able to have an unimpeachable resource around what is the data showing us about what is happening in our healthcare market. And we do have an all-payer claims database in Massachusetts to that end. The law also created the Health Policy Commission, which is the policy side of this in the development hub. And so we use the data and information collected and analyzed by the Center for Health Information Analysis to really create recommendations around how we can best achieve that more affordable healthcare system. So a little bit about the HPC specifically, because it is an important part of our story. We are an independent state agency, as I mentioned. I report to a board. That board is made up of appointments from the governor, the attorney general, and the state auditor, who are three constitutionally elected officers. Each of those make appointments to an independent board of 11 members. Those members have some broad requirements attached to them. For example, one member needs to have expertise in behavioral health. One member will need to have expertise in health insurance companies, and each of them have kind of a different set responsibility. However, there is a financial conflict requirement there. So these are not representatives of those specific industries, rather individuals who have own personal experience and expertise. This board is chaired by Dr. Stuart Altman, who is a longtime healthcare economist, and the board directs the work of the executive director and the staff. All of our meetings are held in public. And we meet approximately every 6 weeks for a full board meeting where we discuss the entire work of the organization in a public setting. And that's an important part of our story. We have a long list of responsibilities at the commission. I will really am here to focus on the last bullet on this page, which is around examining changes to our healthcare marketplace. But we did want to note that we also have responsibilities for understanding what those cost drivers are, making investments in community hospitals, as well as promoting patient-centered medical care that integrates behavioral health. Happy to answer questions about any of those, but I'm really going to focus my comments today on this last bullet, which is around examining significant changes in the healthcare marketplace. As has been noted before, our market structure, a provider market structure matters. It matters for total healthcare spending. It matters for the quality and access of services that they're providing on behalf of citizens. And Massachusetts believes that the very dynamic provider marketplace that we have today, both in Massachusetts and across the country, deserves public examination about what those impacts may be when providers are proposing significant changes. Mr. Chairman, as you said, a concern around the unintended consequences. What we've tried to do is set up a structure for examining, making public and transparent what some of those likely consequences may be so that consumers, businesses, and policymakers can appropriately weigh whether these consolidations are, in fact, within the public interest. And so I want to talk a little bit about how we do that and what that structure looks like. So first, just kind of as a table setting, prices matter, and we know this. The price of healthcare services, both in Massachusetts and across the country, is what is driving overall healthcare spending. We are not using more services than we did 10 years ago. The price for those services has increased. And what we found in Massachusetts, and we know to be true in many other states, is that prices vary significantly for the same types of services depending on where you receive those services. And so this is not correlated with better quality. It's not correlated with higher acuity of patients. But we know that this variation exists. This chart really just shows in these four significant categories of different types of hospitals, the range of prices for the exact same types of services. And what you can see is that in each category, there is a huge range, and across all four categories, a significant range, such that you can have community hospitals that are charging prices requisite with an academic medical center, and much variation in between. We have done an analysis in Massachusetts to try and understand why are this variation in prices, why does it exist, and what is it correlated with? And what we find that higher prices and price variation is a matter of market function and market structure, not on quality of care being provided to a large degree. And so on the left here, you see factors associated with higher commercial prices include less competition, larger system size, corporate affiliations, as well as status as a teaching hospital. Factors associated with lower commercial prices include more government pay. And I think this is an important point because many claim that they have to negotiate higher commercial prices in order to offset losses on the government pay side. What we found in Massachusetts is that hospitals that have a tremendous amount of government pay actually have less leverage to negotiate higher commercial prices and are therefore financially disadvantaged because of that government pay. And finally, factors not generally associated with these commercial prices, quality or the income of the hospital's service area. And we know that this variation exists, and we also know that it's consolidating. In Massachusetts, this is analysis that is Massachusetts-based, but what we found is more than 60% of hospital discharges are now coming out of our biggest healthcare systems, and that more than 3/4 of our physicians are now affiliated with the major largest healthcare systems. So both on the physician side and on the hospital side, increasing consolidation into our largest, most highest priced systems. And this is obviously very concerning to us in terms of our overall goal of being able to reduce healthcare cost growth. So what have we done about this, and what is the structure, we believe a very unique structure in Massachusetts? So understanding that market structure matters, that consolidations and alignments have been shown to impact spending and system performance, the law allows for a new process whereby providers who are proposing new relationships, this can be a hospital proposing to acquire another hospital, a hospital proposing to acquire a physician. It could be two hospitals coming together, not under a corporate integration, but under a contracting relationship, that they, before they can complete that business transaction, must file notice with the state. That notice will clearly state what their goals are for pursuing this new relationship, what they believe their impacts will be on cost, quality, and access. And that notice is publicly put up on our website, and they cannot complete that transaction before they have filed that notice. The Health Policy Commission and our staff then look at that notice and say, do what we call an initial review, a very tight turnaround 30-day review to basically be able to say, is this a significant change to our provider marketplace that we may have some greater concerns about? And during that process, we have the ability to look at the underlying contracts and proposals that the two organizations are putting in place. And we can examine those and we can say, do we think that this is worthy of further review on behalf of consumers and publics before we allow this transaction to just move forward? And so we believe that this transparency and accountability really is around understanding the impacts. And they can be both negative and positive. And Dr. Ginsburg talked a little bit about what some of those positive impacts may be in terms of greater coordination or greater operational efficiencies. But we also know there is a long history of potential negative impacts from market consolidation. So a little bit more about what this is. Once we have completed this initial review, if we have found that we have some significant questions, we can initiate what we call a cost and market impact review. And this is a longer review. It is a more comprehensive review that can take up to 6 months' time. The two parties cannot complete their transaction while this review is being undertaken. It is a comprehensive multi-factor review of all of the different potential impacts that may result from the transaction, and it results in a public report. And this public report, which the parties have an opportunity to respond to, may be referred to the Attorney General for further investigation, but in any case allows for a full public airing of what some of the potential impacts may be. I want to state very clearly where our authority ends. We do not have the ability to block or deny a proposed transaction. We merely have the ability to provide greater public examination of what those impacts may be and to promote a public dialogue about whether they are truly in the public's interest. But we do not have the legal authority to ultimately block a transaction. So in that case, it is different from a determination of need process, and it is very different from an antitrust law enforcement review process. Dr. Ginsburg noted earlier around potentially expanding antitrust. We know across the country that the number of cases that rise to an antitrust legal action is very, very small. And so nonetheless, we think below that level of an antitrust legal action, there are significant impacts that can come from some of these transactions that are worthy of review and public discussion. And so want to make that distinction between antitrust. How we do this process is that we do have the ability to compel confidential information from the parties themselves around their underlying reasons for pursuing these. We do data analysis to understand the market share differences and to where we might find contracts and price differences. That information is collected. We have an ability to keep that confidential such that we're not making proprietary business information available to the public, but do have the ability to report on it in summary form at the end. And then the outputs, as I mentioned before, a preliminary report, a final report, and a potential referral to the Attorney General's office. This slide talks about the factors that we examine when we look at things. And I just want to note, this is not just about market share. We do also examine things like what are the relative quality scores and abilities of the providers who are proposing to come together. What is their role in providing access to populations that are at risk or vulnerable? What is their ability to provide care for government payer mix, and as well as thinking about things that in a normal antitrust investigation would never look at, to think, what are the access implications if these providers come together? Are they planning to close services as part of this consolidation and this new relationship, or are they planning to expand services? These are questions that we would ask in our full review. I know you have all of the slides in front of you, and so I won't talk through all of these. This just kind of talks about how those questions are asked. And again, I think the main point here is that it isn't just about market share. It's about really trying to understand all of the different factors that may result from some of these significant alignments. With my few remaining minutes, what I'd like to do is walk you through an example of how this works, because I think we'll really be able to paint a picture of how this process has worked in Massachusetts and how it intersects with and is complementary to an Attorney General's office in antitrust investigations. So in 2013, our largest provider system, which name is Partners Healthcare, it is our largest provider system in Massachusetts. It's also our largest employer, private employer in Massachusetts, and has a significant number of the physicians that it contracts with, over 8 general acute care hospitals in 5 different regions of the state, so a statewide presence, and generally has among the highest prices for both hospital and physician services of any provider in Massachusetts. In 2013, they proposed to acquire 3 new hospitals and a large physician practice. And this was one of the first cases where they had to file notice with us and go through this review process. The Health Policy Commission received this initial notice, and recognizing the size of both Partners Healthcare and the very significant expansion that it was proposing, engaged in a full review of these proposed transactions. What we found at the end was that the transactions were likely to increase total healthcare spending to a range of $50 million a year as a result of increased prices, both on the hospital side and on the physicians. We also noted and found on the market side that there was a likelihood, a high likelihood of increased ability to negotiate even further price increases in the future, and we did not attempt to even quantify that particular piece. And then finally, we really examined claims and issues around the positive benefits, and where the parties here really made a case that they are coming together to provide coordinated care, that they were going to be an accountable care organization, and that there was going to be significant improvements in the quality and efficiency of the care. We really tested those claims and asked very specific questions about when do you propose to implement these care coordination practices, on what timeline, and what evidence do you have that the so-called positive impacts of this transaction are likely to occur? And we found in this particular case that they did not provide adequate evidence around where the positive impacts may be in achieving kind of the positive side potentially of some of these consolidations. We ended up referring our report to the Attorney General's office. and the Attorney General's office was also in the process of an antitrust litigation investigation of the entities. They ended up, the Attorney General ended up negotiating a settlement agreement that would have allowed the transactions to move forward, but with some specific terms involved in it. The story doesn't end there, and I apologize for the slide. The court in Massachusetts had to review this proposed settlement agreement, and during this process, they asked for public comment from any interested stakeholder. And this incredibly unique experience happened where other providers, health plans, consumer groups, community organizations, businesses, all looked at this transaction and looked at the report that the Health Policy Commission had issued publicly and began to question whether the settlement was truly in the public's interest, and raised a number of questions and concerns about whether the settlement, as had been proposed, was sufficient to really limit some of those potential negative impacts. And so the report really provided a catalyst for a public dialogue around whether this was truly the right step forward for Massachusetts. Finally, the court ultimately rejected the proposed settlement agreement and cited the Health Policy Commission's report as the most important of all the public comments due to our objective, evidence, and rigorous-based investigation. The newly elected Attorney General decided to not pursue another settlement, and finally, the Partners Organization abandoned plans to acquire those 4 new community hospitals. So I highlight this as an example of how this actually worked in Massachusetts, and would say we believe that this public examination created a dialogue that would not have otherwise existed. And so while we didn't have the power to deny, we certainly had an ability to bring rigorous, evidence-based, data-driven information to our state that ultimately resulted in a change of course and action for some significant market actors. So with that, I am willing to, excited to take questions and comments from the board.
Thank you. I believe Senator Woke had a question, and I'm assuming you like California now because it's warmer than where you're back east.
Yes.